stick around. At this time, I would like to formally welcome everyone to Finding Relief, Advances in Shoulder Pain Treatments, which is brought to you by the Cleveland Clinic. As I mentioned, we have a wonderful event for you today with two great specialists, and I'm actually going to begin with introducing our first speaker, Dr. Vahid Entezari. After receiving his medical degree abroad, Dr. Entezari joined Harvard Medical School's Orthopaedic Biomechanics Laboratory for a postdoctoral fellowship. During this time, he received a master's degree in translational research from Harvard Medical School and then went on to complete his internship and residency at the Department of Orthopedic Surgery here at the Cleveland Clinic, and then proceeded to a fellowship in shoulder and elbow surgery at Rothman Institute of Thomas Jefferson University. He returned to Cleveland after completing his fellowship and joined the clinic as a staff shoulder and elbow surgeon. His interests in shoulder and elbow include rotator cuff tears, other tendon and ligament problems, sports-related injuries, arthritis, and trauma. He performs shoulder arthroscopy, muscular transfers, fracture repair, and arthroplasty, including full and partial joint replacements. Dr. Entezari is very active in shoulder and elbow research and has authored a number of publications, several book chapters, and regularly presents his research at regional and national conferences. Wow, Dr. Entezari, what an absolute pleasure to have you. I can't say enough wonderful things about you. Thank you so much for being here with us today. And I'm going to send it over to you.
Thank you, Deanna. I appreciate the introduction, and I feel fortunate that I can actually talk about my favorite topic, shoulder surgery, today, directly with all of you. And let me introduce myself. My name is Vahid Entezari. I'm a staff shoulder and elbow surgeon at Cleveland Clinic and assistant professor. I'm fairly involved in both education and research, but my main mission here is clinical care and taking care of patients. And that's why I love to talk about this topic with you. I'm going to start with maybe talking about the shoulder joint, some basics, how the presentation of shoulder problems, help us diagnose issues around the shoulder, and also focus on rest of my talk on most common problems we face in shoulder that can cause shoulder pain and potentially need surgical treatment. One of the important things about shoulder joint to note is that this is the most mobile joint in the body, and this high mobility essentially comes at a cost that people can injure their shoulders and also over time can develop wear and tear in their shoulders. When I talk to my patients about their shoulder problem, one of the main themes is that they're all active, and whether that means that they have been throughout their life involved in any form of sports, or actually pick that up later in life. But sports becomes a main thread of patients who deal with shoulder issues, that being like swimming, golfing, and any form of overhead athletes put their shoulder through a lot of stress. Another cohort of my patients who deal with a lot of shoulder issues are patients that have highly demanding, physically demanding jobs, machinists, like electrician, people who are involved in construction, or any type of work that involves overhead activity puts a lot of stress on your shoulders. One of the recent changes that I have noticed, and my colleagues as well, is that we're living in a time that we're more active, and that has a lot of health benefits, but also from an orthopedic and joint standpoint. Now we're talking about joints that are potentially arthritic or have degenerative changes, now have to go through a sport or recreational sports later in life, and that actually creates its own challenges, and while we love our patients to be active, that playing pickleball sometimes leads to shoulder injuries, and those are the situations that we have to navigate some balancing between activities and the activities of daily living and recreational sports that we'll get to later in the talk. I thought maybe I will start with simple anatomy. Although this seems obvious, it will be worth mentioning that when we talk about shoulder joint, there are major three bones that kind of constitute the shoulder joint. One is the arm bone or humerus. The other one is the scapula or your shoulder blade, and also the clavicular collarbone meet at this junction and create two joints, one between the collarbone and the scapula that could refer to an AC as a AC joint, a acromioclavicular joint, and the shoulder joint is mainly referred to when the end of the arm meets the shoulder blade. As you can see depicted in this picture as green, both of these bones at the end of them have Cushing's cartilage that allows the gliding motion of the joint, and this is essentially constitutes our shoulder joint. This is a ball and socket joint, and that's one of the reasons we have so much mobility in the shoulder is that this ball can rotate, can elevate, can sometimes translate in the socket and allows for a lot of range of motion. And with that comes like need for stability. And that is provided mostly by ligaments and also muscles that cover around the shoulder. I sometimes like have to go back to the basics of anatomy when I'm explaining to patients when we're talking about surgery is that what these structures are. So rotator cuff are constitutes of four muscles that cover the end of the arm and go into the shoulder joint, and they all create a cuff of tissue that provides stability for your shoulder joint. And as you can imagine, with all the movements that's in the joint, these muscles do a lot in terms of keeping the joint stable, and that's why we see a lot of degeneration and potential injuries in these tendons. Another structure that it's discussed and talked about when we talk about shoulder is a lot is the biceps tendon. As you can see in this anatomy, the biceps tendon is the big muscle in the front of your arm that by definition has two heads, and one head is larger that rarely gets degenerated. But as you can see, the other head gets very narrow and goes through a channel of bone that goes into the shoulder and attaches to another structure, which is very important. It's called labrum. Labrum is this ring of tissue that makes the cup of the joint deeper and also contributes to the stability. And as you can see, labrum becomes continuous with your biceps tendon. These structures are related, so you develop like, labral degeneration and biceps degeneration, and that's why sometimes we talk about these structures in conjunction when we talk about shoulder. When we talk about shoulder pain, it's important to note that this is the second most common reason for patients to seek medical attention, orthopedic attention. And so we see a lot of patients with shoulder problem. One of the things always catches my attention is that I see that in my face of my patients, because shoulder pain is not just shoulder pain, because it affects people's life in terms of daily activity, their work, and sometimes the sleep. So a patient with a chronic shoulder pain can't really have a good night of sleep, and it affects like multiple facets of patients' life. As a shoulder surgeon, there are certain clues when patients talk about their symptoms that help me differentiate pains that are coming from the shoulder joint versus the pains that potentially can happen around the shoulder but not necessarily come from the joint. If you're having pain in the upper arm, pain in the biceps area in the front of the shoulder, pain that goes deep into the shoulder, those are typically related to your shoulder joint, while you can have pain around the neck area, in the trap muscles, in the back of the shoulder, around the shoulder blade, or the pains that are traveling down the arm. And it's important to note that sometimes things that you're feeling around the shoulder might not necessarily come from your shoulder, and sometimes can be related to your neck, nerves that are coming in and around the shoulder. And those are sometimes, overlaps between the spine and shoulder that we sometimes get the help of our spine specialist to address. The problems that lead to shoulder pain can be injury related or wear and tear, or both, meaning that you can have wear and tear in your shoulder as a result of many years of hard work and labor, and have an injury, and on top of the wear and tear, now you have an injury. And recognizing that is very important. When patients show up to our clinics and with the complaint of shoulder pain, it's very important to get a complete history and physical exam, because that way we're not missing a surgery that happened many years ago, or an injury that might have been initially not thought about, like, a major issue. And also, our physical exam allows us to kind of narrow some of these diagnoses to more precise diagnosis. So I think doing a physical exam, so I personally never kind of diagnose. I always want to talk to my patient and listen to them when the symptoms started, how they started, and also do a physical exam. So I actually lay a hand on the shoulder and see. There will be many times that I will look, a patient is sent to my office for a shoulder, potentially a rotator cuff problem. But as soon as they take their shirt off, I realize that actually there's a huge atrophy, and that leads us to different diagnosis, maybe the nerve involved or other systemic diseases that can present. So it's very important to do a thorough physical exam. The second important thing in decision making in the shoulder, having some basic imaging studies. And usually we like to start with an x-ray. X-ray essentially allows you to assess the bony structures, but not just bone, but because the way your bones are lined up in the shoulder sometimes gives your surgeon a lot of information as how the soft tissues are working. Are they competent? Is there a chronic problem in the shoulder that might affect overall approach to the shoulder? For instance, if you have a severe arthritis in the shoulder, the approach to a potential rotator cuff problem in that shoulder might be different. So that's why we want to start with an x-ray. As we move along, sometimes in the process of evaluating a shoulder pain, we need more information, whether or not this is an injury that lead to somebody not being able to raise their arm. That makes me concerned about whether or not they have torn their rotator cuff. So maybe an MRI or an ultrasound would be a good test for that. If they had a shoulder dislocation and potentially there's a fracture in the socket, getting a CT scan gives you a lot of information about the assessment of bony structures, and gives us get us closer to a more precise diagnosis. Focusing on maybe more common diseases that we have in the shoulder, I like to take my time a little bit and talk about rotator cuff disease, because I'm sure all of you have heard about somebody having a rotator cuff surgery, or you had rotator cuff related symptoms. One thing very clearly we have to note that not every pain in the shoulder equates like a rotator cuff tear. So I put this aside because, as you can see, bursa, we have them all around our body, are these pockets of fluid that we have over bony prominences, and we have a large one in the shoulder. And sometimes due to repetitive motion of the shoulder, somebody working overhead, somebody comes and says, yeah, I moved in a new house and I wanted to paint my house, and after like a week of painting, my shoulder is like throbbing. A lot of these type of repetitive activity related pains are not necessarily are related to tear, and you can actually make your bursa or the tendon inflamed without tearing them. And that's why sometimes getting the imaging studies help you differentiate some of these diagnoses. So impingement is another symptom. We tend to kind of put a set of symptoms of somebody raising their arm and feeling pain in the lateral aspect or upper arm area. We tend to call that an impingement, but not necessarily having an impingement symptoms means that you have a rotator cuff tear. So I just wanted to clear that. So you sometimes okay, so I got to go and see a doctor immediately. You definitely want to seek attention, but not necessarily that means a tear in your shoulder. Another thing is that something like a biceps tendonitis can happen in a shoulder alongside a rotator cuff disease. So we tend to approach these problems at the same time, meaning that when you're getting cortisone injection or your physical therapy, that will help with the biceps related symptoms. And sometimes these things get addressed at the same time during the surgery, and definitely paying attention to pattern of pain also helps. In rotator cuff disease, because it's a very common, especially in our aging population, a lot of times we want to start with the least invasive approach in addressing the pain. Maybe, as I said, you had certain activities, increase your, being active, increase your activities, and your shoulder is just inflamed. That's why we want to give this episode time with modifying your activities, having you ice the shoulder, use anti-inflammatory medication, and at times use a cortisone injection to calm down the inflammation and do some physical therapy. One of our excellent physical therapists is on this call, is going to teach us about the how physical therapy is going to work in this setting, and I'm looking forward to learn from her. But point being, some of these steps are usually taken before the patient gets to my office for discussion about surgery, but it's important to methodically go through those steps. So sometimes my patients ask, like, how injection is going to help with my pain. So as you can see, this is a depiction of a bursa in a shoulder that has gotten like red and inflamed. And by putting a cortisone injection in this area, you reduce the inflammation, and that bursa turns from an inflamed bursa to more of a normal bursa, to reduces your symptoms of impingement, and that helps with, like, being able to move the arm better, do more easier physical therapy, and the patients will be happy. One of the kind of progression of the symptoms is that, okay, is now we are talking about real problems in the shoulder, but is every tear in the shoulder require surgery? The answer to that is no, because as we age, our rotator cuff tends to thin out, and from a population standpoint, a lot of people are living with rotator cuff disease that don't have any symptoms. That becomes like a little bit of an art, how to approach this, and maybe not rush into the surgery in every situation. You sometimes might read in your MRI report that partial thickness tear, and that means that some of the tendon is left on the bone, as you can see on the left picture. And the full thickness tear means that your tendon is completely off the bone. But again, the size also matters. You can have a full thickness but small tear, and those are also commonly treated without surgery. And again, where the tear in your shoulder also matters. Is a tear, what part of the tendon, how many tendons involved? Those are the things that your surgeon is going to glean from MRI and bake those into decision making. What other factors we use for making a decision for surgery for rotator cuff? Age is certainly a factor. When my 75-year-old patients come and have an MRI that had a rotator cuff tear red on them, I have to kind of orient them and say, a lot of patients in your age group actually have rotator cuff tear, and we have to kind of tie that into all the other factors that we see in the shoulder to see truly a rotator cuff surgery is a solution, or we have to talk about other options, maybe non-operatively or operatively in the realm of joint replacement to address their problem. How active the patient is, their job demand, and their range of motion, whether or not they have weakness, and also overall health of the patients. If a patient have diabetes, their diabetes needs to be well controlled. If their A1C is like, very elevated, that patient is going to have hard time healing the tissue. That's why we a lot of times want to optimize our patients before this type of surgery, so that they don't go through the surgery and don't have the expected outcome, because their essentially overall health affect their ability to heal. And also there are some modifiable risk factors, such as smoking. We know that patients who actively smoke through a rotator cuff repair have much higher rate of failure of their surgery. So we try to counsel patients about stopping that. And there are certain diseases, right, rheumatoid, that affect healing of the soft tissues. And also you can be on medications that affect your healing because of that. And as you can see, this is a multifaceted decision, and not always a positive MRI means that you need to have surgery. And that's why we sit down and kind of slow down and talk about all these options with patients. Generally speaking, if you have a smaller partial thickness tear, your tear is chronic, and you are at an older age and you don't really have a high demand job, we try to start with a conservative treatment. But when the tear is large and maybe acutely happened after an injury, and you're young and active, you probably closer to a surgical option. But as you can see, a majority of patients are in between these two extremes, and that's where the decision making with the help of the patient is very important to come up with the right diagnosis and right treatment. So very similar to approach that I said, we try to modify activities, use anti-inflammatories, maybe at times try cortisone injection. It's one of the tricky issues is that if the surgery is on the book, sometimes we don't want to put a cortisone injection in the shoulder. At times I get asked, like, can I get an injection before my surgery? Probably that's not a good idea because it slows down the healing potential, and physical therapy is an integral part. When we talk about arthroscopic rotator cuff repair, which is the mainstay of nowadays treating rotator cuff problems, has become a very effective, tool to treat patients' symptoms because we don't make big incisions in the shoulder. Surgery is done through poke holes around the shoulder with instruments that we introduce into the shoulder, and from that perspective, accelerates patients recovery. One other aspect of rotator cuff repair is that we now use blocks that control your pain after surgery. It used to be that rotator cuff surgery was a very painful episode for patients, but I would say with nowadays using catheters or nerve blocks that your anesthesiologist under guidance of ultrasound does that before surgery has changed the experience of the surgery, and patients are not having severe pains after surgery that they have to deal with. At times, these blocks can numb the entire arm or the shoulder region area, and patients are actually quite satisfied with the results. With the advancements that we have in recent years, we have also options to augment the rotator cuff, especially the rotator cuffs that are large or maybe priorly failed, is that we have patches and grafts that we can add to the rotator cuff repair. There's interspace balloons that we can put to cushion the joints and potentially protect the rotator cuff tendon, and also options for muscle transfer that happens to be part of my practice in younger patients that have no other options if their rotator cuff tears are big and chronic. In terms of recovery, it's important to note that rotator cuff surgery is a surgery that it takes a long time to recover from. That's important from a work standpoint and life standpoint, making the right arrangements so that you can go through the surgery. This is part that we really, my office and my nurse and my PA work really closely with patients to make sure that they have the right essentially cadence in terms of planning ready for surgery. So we're not throwing someone in the middle of a surgery that's difficult to recover from with no preparation. When you think about how the tendon heals, it's a very slow process, and that's why there's a period of immobilization after this surgery is involved. And that tends to be the hardest part for people, like putting them in the sling and telling them not to use the arm, especially if it's their dominant arm, an active person. Sometimes it's hard, but it's very important that you follow the protocol so you have predictable outcome. And then you transition from there to a period of time that you work with your therapist and passively move the arm to resolve the stiffness, and from there to strengthening the arm so that you can get your function back. So that's like a very brief overview, and obviously there's going to be a lot of questions that I'm happy to answer about the rotator cuff, but I'm going to move to another topic, which is frozen shoulder. And in frozen shoulder, the patient loses the global range of motion of the joint, and they're quite actually painful. And when you think about it, this can happen to up to 5% of general population throughout our lifespan. And so it's not a very uncommon thing. So you hear so-and-so had a frozen shoulder, or you might have had someone in your family had a frozen shoulder. This usually happens in people in their 40 to 60 year of age. It's more common in my female patients, and the risk factors are like having a diagnosis of diabetes or thyroid issues or Parkinson's disease, or sometimes it can happen out of the blue with no risk factors. As you can see in this picture, the lining of the joint that usually is very thin and malleable in a patient with a frozen shoulder gets very inflamed and thick, and that's why you start losing range of motion in the shoulder, and becomes very hard to move the joint. So the treatment for this usually is a cortisone injection that we try to reduce the inflammation in the shoulder, and putting you through physical therapy and intense stretching exercises that usually gets the shoulder back on track. When these approaches fail, sometimes you have to use more invasive procedures like hydrodilation, that someone put fluid in the shoulder and it kind of expands that capsule of the joint, or you might need surgical intervention for this. But we always want to go through this step by step and not jump to the surgery. right away. The goal of the surgery is to kind of release this inflamed layer of tissue so you can get the range of motion, and we usually get the patient back to do physical therapy right away for them to be able to maintain their range of motion. Lastly, I wanted to talk about shoulder arthritis, which is nowadays is a very common problem in our aging population. As you can see, the lining of the joint or the cartilage can be thin out, and you might have at times bone-on-bone arthritis that creates friction and pain and affects your function and sleep and causes pain. So there are different types of arthritis in the shoulder. One is, as I said, is wear and tear, but you can also have arthritis in the context of an inflammatory arthritis, which is inflammation in the joint and structures around it can cause like pain and go through flares of pain in the shoulder. You can have like an injury, like a fracture or dislocation to your shoulder that over time leads to development of arthritis. And also the most common one in my aging patients is that the rotator cuff disease or the surgeries that you previously had to for the rotator cuff might lead to arthritis in the shoulder. What all of these problems have in common is that they create pain. They don't allow the patient to have a restful night of sleep, and they cause stiffness, and sometimes you lose your overhead function and can have clicking and crepitation because of the loss of that smooth surfaces in the joint. And at times you might experience instability in the shoulder, feel that your shoulder want to pop out of place because the rotator cuff is torn around the shoulder. Very similar to other problems in the shoulder, we try to modify activities and initially treat these problems with conservative approaches. One of the questions I always get is that how many cortisone injections I should have before I should have surgery. And rule of thumb for me is that if you can manage your symptoms with the maximum 2 cortisone injection a year every 6 months, that means that the cortisone injection might be a solution for some of these chronic problems. If you're getting a cortisone injection every 3 months and you're waiting to get to the next cortisone injection, probably you're masking the symptoms with cortisone injection at some point. Maybe it's better to talk about other options. And physical therapy is also tricky in the context of arthritis, is that if the lining of the joint is lost, sometimes physical therapy actually makes your symptoms worse. So that's why I recommend talking to your surgeon and seeing what might be working in your scenario. At times, if the arthritis is not very severe or the patients are young and we don't want to jump into a shoulder replacement option, we do an arthroscopic cleanup procedure before joint replacement. And obviously, it's important to notice that this is not a surgery that we actually address the arthritis, but we maybe clean up the joint and reduce the symptoms. And so over time, it might fail, and you might eventually anyway need, a joint replacement. But sometimes for a young person, it's good to buy some time. You are going to hear from your surgeon to talk about different types of joint replacement. Here I have 2 pictures of a regular replacement, which the ball is on the arm side and the socket is on the shoulder blade side. And in cases that we have really bad bone or the soft tissues are not competent around the joint, we might go to a reverse shoulder replacement, which we reverse the relationships, and now ball is on the socket side and socket is on the arm side. And I tend to take my time and sit and explain these things, and so that the patients understand what type of surgery they get and why we're making these decisions for them. Usually patients for joint replacement go through a very complete set of pre-op evaluations. We get an x-ray, we get a CAT scan, so we have a detailed analysis of the joint, and so we can actually plan the surgery. You will get some blood work done, and also always we want you to be optimized for these surgeries. If you have a condition chronically that you take medication for, usually we refer you to the cardiologist or pulmonologist so that they can actually prepare you and optimize your condition for the surgery. In terms of recovery, it's always good to note that my patients who go through joint replacement actually has a different experience than patients that go through the rotator cuff repair. Joint replacement, because we replace parts, has less dependency on the healing, and patients tend to recover faster, although the surgery might be more involved than putting an implant in the shoulder. But patients' experience is different. They have less pain and the recovery is faster. And I would say you tend to maybe stay in the sling for 2 weeks as opposed to 4 to 6 weeks for rotator cuff, and you quicker go through the physical therapy. That's why sometimes like patients had a rotator cuff repair in the past and they're scared about making a decision for shoulder replacement, and we have to sit down and explain that this is a totally different experience. One of the important things also note is that in recent years we have had a lot of advancement in the realm of shoulder replacement. Now we have better implants that are smaller, better, they're 3D printed, and they have a quality that we don't need to. On the left, you can see we used to put very large implants in patients' body. On the right, like, are more modern implants that are much more low profile. They preserve bone, and we don't have to actually go down and remove a lot of bone for doing the surgery. And I think that translates into having less pain and faster recovery for our patients. One of the very important advancements is having a multimodal pain control. Our anesthesiologists, like nowadays, like put nerve blocks and you start on pain medication earlier. So I think overall the experience of surgery has become less painful for patients, and they have much easier time recovering. I mentioned that we get CAT scan, and these CAT scans actually has led for us to be able to plan these surgeries virtually. Essentially, before surgery, I put the implants, different size and shape implants on the patient's shoulder, and this will allow us to make essentially less decisions in the surgery and going into surgery knowing what exactly the shape, form, and size of the implant that fit best to your shoulder. And I think has led to having less complications and better range of motion after surgery. We also are very fortunate in Cleveland Clinic that have access to very cutting edge technologies such as mixed reality, virtual reality for navigation of the surgery. And also soon we're going to have robots like, helping us perform shoulder surgery that are going to make us much more accurate in terms of performing the surgery. So overall, I would say shoulder surgery has dramatically changed in recent years. We have a lot more options, a lot more ways to actually ease the pain and the symptoms of the patients going through the experience of the surgery. And I think I use this opportunity to say that we'll be happy to see you if you have a shoulder related problem, and I'm obviously happy to answer all your questions. But it's my team, myself and my PA Sean Collins. We were essentially covering a very large geographic coverage. And if you have a shoulder related problem, would like to see you, and I'm happy to kind of, depending on what the problem is, sit down and talk about options with you.
Thank you so very much, Dr. Entezari. What a wonderful presentation. I know that already you have answered many of the questions that we've received upon registration and throughout the event. So thank you very much. That was very informative. We are going to welcome Dr. Entezari back at the latter half of our event for our questions and answers. And now it is my very distinct pleasure to introduce our next presenter. I would like to introduce to you Kelly Kinsey. Mrs. Kinsey has 32 years of physical therapy experience. Wow, that is fantastic. With an emphasis in orthopedics and sports medicine. She's currently working for the Cleveland Clinic in Avon here in Ohio as an outpatient physical therapist. She is certified by the American Physical Therapy Association as a specialist in orthopedic rehabilitation and has presented continuing education lectures on the shoulder joint as part of the Cleveland Clinic Orthopedic PT Residency Program. Kelly lectures both locally and nationally on various topics, including shoulder rehabilitation, functional rehabilitation and testing, and muscle energy techniques. Additionally, Kelly has been an adjunct faculty member at Baldwin Wallace University for over 10 years, teaching therapeutic interventions. She received a bachelor's degree in athletic training and in exercise science from Miami University and went on to receive her master's in physical therapy from the University of Indianapolis. Kelly, thank you so much for joining us. We are so excited to learn from you as well. I know Dr. Entezari mentioned that he's very eager for your presentation. So without further ado, I'm going to let you take it over, and we will see you both back for the Q&A.
All right. Thank you. I appreciate it. Well, welcome. I'm happy to be here to talk to you about shoulder rehabilitation and give you an idea of what we do every day in physical therapy. An overview of what we're going to talk about today is giving you an idea of the rehabilitation process. People come to see us and they're not really sure what to expect or anticipate. I want to apply some of those principles we're going to talk to about the shoulder specifically. And then I know everybody's interested in learning a few exercises or things you can do, or what we might be doing as well in the physical therapy realm if you came to see us for your shoulder. So first, let's talk about the rehabilitation process. It is a journey. You will start with an evaluation, you'll have some treatment, and then the hope is that you're discharged from physical therapy feeling a lot better. What should you anticipate or expect in the evaluation? Well, when you come in to see us, we really are interested in getting a feel for the story. You know, what happened to your shoulder? What kind of pain are you experiencing? What kinds of things are you hoping to be able to accomplish or do? So that's a really important piece of the rehabilitation process, is getting the information from our client or our patient. We also are really concerned about what is your personal goal. What would you like help with? Is it being able to sleep better at night? Is it being able to pick up your grandchild? What exactly would be success for you? We then take some measurements, with like a little tool called a goniometer, or look for your strength and really watch you move and poke around a little bit. And the goal there is to figure out what is causing the particular problem in your instance. So we're determining what tissue might be aggravated or what kinds of things you might be doing in your life that might be contributing to your discomfort. And then we try to set up a plan with you. It's an individualized plan that would try to address the issues you're having and help you try to reach your goals. So we then would start a treatment. The treatment in physical therapy is usually strongly based in exercise. Exercise has been proven to be the most important and influential modality or thing we can do to help you with your shoulder problem, as with many other injuries in your body. Modalities might be utilized sparingly. Modalities are things like ultrasound, electrical stimulation, maybe dry needling, massage. Those are things that can help support the exercise that you're going to learn to do. We typically will give you an exercise homework and then have you come back and report to us how it's going. And then we need to adapt what you tell us. Are you getting better? Are you feeling worse? So that we can best address your particular issue. The exercises we choose are based on two major things. One is the stage of healing you're in, and then the impairments or the problems that we've identified in the evaluation. The stages of healing are really important. People can be coming to see us after an acute injury, meaning it just recently happened, and they could be in the inflammatory stage, when something is red and swollen and irritated. And that stage of healing usually lasts between 1 to 7 days. So if somebody comes to me day 2 of an injury, I'm not too concerned yet, because they're supposed to have some pain and inflammation. That's a normal part of healing. But then we want you to be able to progress yourself through the different stages of healing to get to the point where it's not bothering you. While you're going through those stages of healing, we can, with exercise, help promote the strength of the tissue that's been damaged or injured and try to come out ahead with having a stronger, more resilient piece of tissue. The other part of rehabilitation is taking those stages of healing and adding some particular interventions. We call treating the impairments what we do in physical therapy. The impairments we're looking for to give you some exercises or some education on how to deal with either motion problems, what we call mobility issues, or stability and positioning issues. And then we'll look at strength and your control of your arm and your shoulder. And then in the end, we're making sure that you have the endurance and the ramping up of your skill or your activity to build up a nice, strong tissue and be able to do what you want to do. We address these problems usually in a systematic way. So I'm first going to make sure you have the right motion and right position before I really focus on your strength. And then I will layer that to your endurance and maybe whatever skill or activity you're trying to get back to doing. The goal is to reach discharge and meet all your goals. And, that would be the, treasure at the end of the process. Therapy can take 1 to 2 visits. It could take a couple months. It depends on your particular issue. We also discharge patients when you fail to make progress. So if physical therapy isn't working for you, this is when we refer you back to your physician and you see what other opportunities there might be for you to treat your problems. If you no longer require what we call skilled care, physical therapy is based on needing the skill of a physical therapist. So although you might like coming in to see your physical therapist to help you with your exercises, we can only continue to see you if you need our skilled care. And most often people are agreeable to continue on with a physical therapy or a home program to maintain the benefits that they've gained. So what kinds of things do we do, particularly to the shoulder? We know that the shoulder, as we talked from the doctor, is that the shoulder has some unique qualities in movement. So it requires a balance of being able to move and be mobile, but also to have some strength and stability. Common impairments that we're finding in our evaluation that deal with mobility or motion are usually addressed with range of motion exercises, maybe manual techniques. We might lay our hands on the body and try to move your shoulder blade or your shoulder, do some soft tissue techniques in order to loosen it up and try to help you get that mobility. In rare cases, you might be given a mechanical device, maybe with a frozen shoulder, and then stretching exercises. Stretching is slightly different than range of motion exercises, and we can teach you some things to keep your flexibility. A big common impairment with the shoulder that we address in physical therapy is posture. Habitual postures and positions can throw off your delicate balance and the mechanics of the shoulder, and that can potentially lead to overuse of certain tissues and degeneration or wear and tear of those tissues. So you'll probably find that your physical therapist is a little bit of a posture police when it comes to the shoulder. You can see from the picture that if you hold your head in a forward position or a little bit of a rounded posture, it can influence the strength and the flexibility of different motions around your shoulder. And these can change the mechanics of your shoulder and lead to pinching or rubbing or compression, and that might lead to pain. So sometimes the simple solution is for us to work on your position and your posture. Posture does affect the position of your shoulder blade, and if you raise your arm up when your shoulder is forward, it oftentimes pinches and causes you something called impingement, which we already heard about. So if we don't want that tissue that's getting pinched to hurt, we need to change our position. Easy things that we usually implement are, one, having people sit with upright postures, even if you're, somebody who's just sitting watching TV, or if you're all day at a computer. These positions can cause imbalances in the shoulder that we need to address. The middle picture is showing you a stretch we use commonly for stretching the pectoralis muscles in the front of the shoulder. We also encourage people to pinch their shoulder blades back to pull those shoulder blades back into place and create a little bit more space for the humerus to move. A common problem with posture and positioning is sleeping. There are many different ways that we try to improve your positioning with sleeping, but one of them is making sure that you have a decent sized pillow that's supporting your head. If you tend to put your arm under your pillow, trying to support your head at night, that can be the biggest problem that you're having with your shoulder. If I don't tell you to bring your arm down below your head, then you may continue to have shoulder pain, even if you do all the right exercises. So having your arm below shoulder height with sleeping is encouraged. If it's the other arm that's bothering you, we tell you to build up like a pillow wall, kind of support the arm so it's not falling over in front of you. So there are many little tricks we have to help you if you're having pain with shoulder pain during sleeping. A common thing that we do in physical therapy is work on strength. So once you've improved their motion and their positioning, we want to create a nice, strong shoulder. Certainly, we focus our exercises on those areas that tend to be the most involved or weak. In the shoulder, there's a balance that has to happen to have good mechanics, and it's a shoulder balance between the deltoid, the muscle on the top of the shoulder, cap of the shoulder, and those ones underneath called your rotator cuff. I started the rotator cuff because that's the group that tends to be a little bit weak and influence a change in your mechanics that might give you pain. When we look at the shoulder blade muscles or the scapular muscles, your upper trapezius, or the muscles that kind of hold your neck up tight, tend to be overfiring. And we need to encourage the muscles in the back to do a little bit more of the work. And that, again, opens up the shoulder joint and gives you better mechanics, less wear and tear. So there are some common exercises that we tend to give over and over again. What kind of exercises would you anticipate if you had surgery, or if you're trying to avoid surgery, or if you're just trying to prevent having a shoulder problem? Post-operatively, we do start with a lot of the surgical patients passively. The physicians don't want us to disrupt the repair that they have performed, and we need to let the body go through some of those stages of healing. So although you're in a sling, we'll take you out of the sling to perform what we call passive range of motion. So the therapist will perform passive range of motion in the guideline motions that the doctor has prescribed, and try to get you as much motions as you can without increasing your pain. Some exercises may be given to you to keep working on your passive range of motion at home as well. If you are trying to avoid surgery, or if you are not having surgery, but you're having difficulty lifting your arm or moving your arm, we sometimes start with exercises that are assisted. If you're having surgery and you've moved past the passive range of motion stage, you also will be working on assisted motion. Many times we start you lying down to reduce the stress on the tissue, and have you use maybe a stick or a cane to help you lift your arm overhead. And maybe you advance to walking your fingers up the wall to try to assist in lifting your arm. Those are called assisted active range of motion. If you can lift your arms overhead, eventually that's called active range of motion. It's the beginning of the strengthening phase. These early exercises are done frequently and gently at home. The usual prescription is try to avoid any exercise that gives you a pain of more than 4 out of 10. And if you are having pain more than a 4 out of 10, we need to adapt the exercise. If you, again, are non-operatively progressing, or post-operatively you're improving, we move you to a phase where we're working on stretching and strengthening. For stretching, your range of motion exercises may eventually be a slightly more aggressive, trying to create more flexibility. We tend to hold our stretches longer than our range of motion exercises. These can be preventative exercises as well, but there are some classic exercises that maintain the mobility of the shoulder. If you're performing stretches, it's a common thing for you to hold those stretches without tugging and bouncing for a gentle or a mild stretch for about 20 to 40 seconds. 3 repetitions is plenty. Strengthening, we perform progressive loading. The tissue is trying to regenerate and remodel. We're trying to make it more resilient. So we start with easy exercises and slowly load or add weight to build it up. So the idea is to build a strong foundation before you start asking your shoulder muscles to do more. Some classic exercises are working on shoulder blade exercises with the row using a rubber band. And you'll see people laying on their side doing a small weight for rotator cuff exercises. The key to preventing a problem, if you can, is thinking about fitness. A well-balanced stretching and strengthening program can go a long way. Of course, we always need to look back in at that posture piece. You want to be doing some stretching and strengthening in good upright positions, as well as making sure that you're not slouching on the couch all day or sitting on your computer in a bad posture, because those things can, over time, cause problems. We want you to monitor for signs of overload or working too fast. Patients oftentimes get some exercises off of the internet, or maybe pictures from their primary care physician to try to address their shoulder pain. Although well-meaning, oftentimes our patients will tend to do too many of the exercises, or they'll start off at too high of a level for where they really need to be. Maybe they needed to start with the motion part and they started with rubber bands. So it's important to know that if you're having pain with your exercises, you might want to actually see a physical therapist. For fitness, stretching is often recommended for 3 to 7 times per week. Usually you can't overstretch. So stretches can be held for 5 repetitions, 15 seconds, or maybe a little bit less repetitions and hold a little longer. For strengthening, the recommendation is to do some exercises 2 to 4 times a week. Pick 4 to 8 exercises that you enjoy doing, and maybe you start off with just doing one set of 10 repetitions. And if you like exercising, you can build that up to doing 3 sets of 10. The idea is to slowly build that strong foundation. I thought I'd give you just a few pictures of some exercises that would be a balanced home exercise program. It might be something that my patients post-operatively would be discharged with. You need to be careful not to just jump in and do some of these exercises unless your shoulder isn't hurting and you just wanted a strength training program. But you need to be careful. The exercises I'm showing you here are large muscle groups. So doing a rowing exercise with a rubber band, the focus is on pinching the shoulder blades back, not pulling the band hard back as far as you can go. So engaging those muscles between the shoulder blades and improving your posture. The balancing exercise to that is doing a pushing exercise. It's very easy to start doing a push-up exercise on a counter or on a wall, and then build up the strength to be able to move yourself to more of an angle over time. I would work large muscles groups first, and then maybe move to some of these. The first exercise on the top is a lateral raise. It's really targeting your deltoid muscles, one of the main movers of your shoulder. Sometimes people tend to lift their arms a little bit too high, and that can cause pain and impingement. So the goal here is only to raise your arms up to the height of your shoulder and not above. On the bottom left is a great exercise that hits a lot of the muscles in the shoulder joint. It's performed with your arms in about a 30-degree angle or like a Y or a V position, and your thumbs facing the ceiling. You would lift a light weight up to about shoulder height and then let them come back down. That really targets one of the rotator cuff muscles that we see most often injured. And then some classic rotator cuff exercises you see in the middle and to the bottom right are rotating in and rotating out using your rotator cuff muscles. If your rotator cuff is weak, this is a very safe position to start doing some rotator cuff exercises. Again, you have to start very light and feel like you're almost doing too little rather than starting where you feel like you're pushing yourself hard and having pain. So fitness and prevention really overlap, and it is where we try to go with our exercise program, even post-operatively. You need to start slow and progress over time and monitor your discomfort. 1 set of 10 repetitions is plenty for some of these exercises. And then if you can increase the number of sets or the repetitions, I would do that prior to adding weight. As little as 3 to 5 pounds is a progression for those large muscle groups, and a 1 or 2 pound weight can be more than enough for those small exercises. So some key takeaways. I know I can't really address every specific problem, but the big picture is important. If you're having pain, you can seek an individualized assessment first from a physical therapist. Everybody in my physical therapy department, as well as throughout the Cleveland Clinic, are well trained in how to treat shoulder problems. A generalized fitness program is the best prevention, listening to your body, avoiding those positions that hurt. And then remember, posture is really important. So keeping yourself in a more upright position can be the single solution you need. And although not every problem can be fixed, right, oftentimes we can improve your discomfort. And if you have a rotator cuff tear, we sometimes can work with those muscles around the shoulder to help them come and give you a little bit of support so that that other one isn't hurting. So it's really about kind of coming up with an individualized program that would be unique to the person. So thank you. I appreciate talking to you about the shoulder, and I know we're going to answer some questions.
Thank you so very much. I really appreciate that. What a wonderful presentation. I want to thank you both for your time. We had received many of your questions, many of our viewer questions upon registration. We want to thank you for those very thoughtful questions. Our presenters did have a chance to view those and really incorporated a lot of those questions in advance. So thank you both for taking a look. But we want to get into some more detailed questions and, of course, reiterate some of the talking points that we hit. So I'm going to pose some of these questions to you, and please take your time. For those who are viewing, if you would like to submit something, we will do our best to try to get as many questions in as we can. The first question I want to ask is to you, Dr. Entezari. How does someone know when they are 100% absolutely ready for a shoulder replacement?
That's a good question. I mean, I would say I try to kind of maybe put a couple of like bins that when we talk about shoulder replacement, because this tends to be a life altering surgery in a sense that most of the patients that come, they have quite long history with the shoulder in terms of pain, in terms of stiffness, lack of function. And most of them have found a way to kind of get around that with like either reducing their activity or maybe having their rheumatologist or primary care physician or an local orthopedic surgeon give them cortisone injections. So first thing is like recognizing that this does not need to be your life. Like, like a lot of times like this mental situation of, well, I'm trapped. Like this is my function. I won't be able to hang my coat ever on a, coat hanger. I won't be able to have, and that's like working through that perception is the first step for me is like, no, there are options. There are solutions that can actually give your function back. And a lot of times in retrospect, when we talk about, how the recovery went for most of my patients, they're like, I don't know why I waited so long, or I kind of like could have had this, a long time ago. And so I would say certainly make that first step by talking to a specialist so that you know your options. Don't accept whatever function you have had or the pain as like, the destiny. And that's the number one, kind of mentally going over that hurdle. The second is to knowing that everything you do, like a cortisone injection or delaying surgery, has cost. Meaning that cortisone injections a lot of times, like, soften the bone and soft tissues and lead to even further, deterioration of the rotator cuff and progression of arthritis. And also in shoulder, we have very small amount of bone to work with. And sometimes it's like, these delays in surgery leads to you actually losing options, meaning that you could have a regular replacement. Now you come like 5-10 years after kind of living with it, and you get an x-ray or CT scan and know that there is like, very little bone stock and you have to go with a different option. So I would say getting engaged with a specialist, asking the right question, and also at least knowing your options is the first step. And when it comes to a patient making a decision for surgery, I would say, the most important thing is that they're medically ready. It's like, most of my patients who are in the age that they will get shoulder replacement, there's some other like a high blood pressure, they have gone through a stent place, they are taking blood thinners, and knowing that we can work around those medical conditions with the help of excellent cardiologists or internists that we have in Cleveland Clinic that get the patients optimized for surgery. And lastly, obviously there's some recovery involved with every surgery, and knowing that you have enough help around. Like most of my patients is like, I'll call my uncle that I helped them doing their surgeries, and now it's their time to pay me back. And so, or my kid, has time over the summer that they're working less, and they can kind of help me. So making those arrangements so that you have the help that you need to recover from surgery is important. Sorry if I gave you a very long-winded
No,
answer, but I feel like sometimes there's a lot to clear up in that question of when am I ready for surgery?
yes. No, that was perfect. And actually, I have a follow-up question for you. Let's say someone does live on their own. Is that something that they're going to be able to manage after surgery on their own, or is it in their best interest to see if somebody can potentially stay with them?
That's a good question. I mean, you go through general anesthesia, and I always ask patients, regardless of being, alone or living with folks, like the first few days after surgery, you want to have somebody around, because as predictable as we want to make this process, go, is still human body, and there's some, unpredictability. So having, like, at least for the first 2-3 days after surgery, someone that can be with you, and like in the cases that you need help, it's just like a pure kind of common sense, more than medical necessity. But just beyond that point, I actually have a lot of patients that live alone, and as long as you plan for these things, goes a lot easier. Meaning that, if my office, or we know that somebody will require, like, admission to a nursing home or a rehab facility, it's a lot of more preparation that can go into surgery than just like kind of throwing yourself into it and figuring out, like, the kinks later. So I would say, bring those conversations up, like, as we're discussing the decision for surgery, make arrangements, and know that recovery from shoulder replacement is not as hard as hip or knee replacement in some aspect, because you don't walk on your shoulder. Like, you kind of like don't need your shoulder for ambulation. You want to go to the bathroom, you can put your arm in a sling and get to the bathroom. But on the flip side, the falls and injuries tend to have far more consequences for your shoulders, meaning that somebody who has poor balance have to have a walker or have to have a cane. Those patients, I personally worry that, like, putting them through a shoulder surgery is going to affect their balance, and they might, have to break a fall, and then have, like, God forbid, dislocation or fracture. So all of those, like, conversations we try to have, like, extensively before surgery, so we know somebody has in the right, environment to recover from surgery.
Perfect. That is excellent. Thank you. So the next question I have is for you, Kelly. So we've discussed a lot of what shoulder pain could be. Is it rotator cuff? Is it frozen shoulder? Regardless of what that pain may be, how does someone know when they're experiencing pain in their shoulder? How do you know if the exercise you're doing is causing more damage than actually helping?
That's a good question. And that's kind of, I alluded to the fact that people sometimes have shoulder pain and they might just pull up some exercises or do something they knew in the past and try to do some things. And I would say the biggest thing is monitoring the result. So if you're doing an exercise and you feel like this feels good, I'm doing a stretch, it feels good, and I'm not feeling any negative effects after, you're probably safe. Is it going to be helpful? We don't know yet, but at least you're not doing any extra damage. But if you can utilize that pain scale I mentioned, the 4 out of 10 seems to be a key part where you might be doing something like strengthening a weak tissue and you'll get a little discomfort. But if you can keep the number below a 4 out of 10, you might get a little soreness, which might be desired, but you're not going to flare it up and go backwards. And so that's usually what we talk about, is managing that. Also looking at how you feel the day after your physical therapy exercises. When you wake up the next day, are you more sore than you were the day before? If you are, then you probably did too much. So we can adapt it. We can do a little less, fewer repetitions, a less aggressively. We don't usually get rid of all the exercises if you're sore. We usually have to tailor it so that you're getting the improvement without the negative effects of overuse.
Perfect. Thank
Yeah,
you.
can I ask Kelly a question so she educates me as well?
Of course.
So I have a very, this is your area of expertise, and I'm asking because I want to, learn and understand this a little bit better. So what I have always, like, seen my patients try to do is, like, maybe pick some exercise and say, oh, I'm going to do this for like 40 minutes, so I'll get more out of it. Like, continuously doing something over and over, versus, like, some of them maybe are more consistent with maybe frequency, like, doing something, giving their body time to recover. Is that a better approach of saying, like, I'm going to do an hour of therapy, or doing, like, things that are really hard on my shoulder, or no, picking some simple things that you do frequently, and maybe the outcome comes from your consistency, not from, like, doing something really intensive?
Absolutely. Yeah. And that's, so the hardest part is figuring out somebody is gung ho. They want to like make this better. So they try extra hard to be compliant and work really hard. And maybe they do too much. And so if we can add things and layer them slowly, maybe you start with 2 to 4 exercises, make sure those don't aggravate you. And then we can kind of add 1 or 2 at a time. And that way, if one is a bad exercise, you'll say something just changed and you'll know what it is. If you do 40 minutes of exercise, you might have done 4 good things and 1 bad thing. And we would think that all of it's bad. So doing it in a very layered approach is nice. Early on in physical therapy, you'll usually do exercises maybe twice a day. Maybe occasionally 3 times a day, depending on what we're doing. But when we get to the strengthening phase, we're usually doing less. So instead of strengthening 3 times a day, you'll probably be doing it every other day. And so it depends on the type of exercise as to the frequency we do. But absolutely, the light, gentle ones we would do to build that foundation. And then you work on the harder ones and you'll do less of them.
Perfect. Next time I say that, I will say I run it by a very experienced therapist.
There you go. And that's why we do these events, so that we can all have the information. That is fantastic. And can I just add on, I have kind of like the adverse question. Do you run into somebody, because I have to tell you, I have run into people like this myself, and I may have even been somebody like this myself with a past injury, where I was very hesitant to do the physical therapy at home, or somebody we know is kind of, I don't want to do that, I don't want to push it. What would you tell that person? What would you say to somebody if their loved one or they're admitting to you, I'm not really doing it as much as I should be? What would you say to that person?
You mean they're not being compliant with the exercises we suggested?
They are not being compliant. I have done that myself.
Yeah, sure.
I'm embarrassed to tell you.
All the time. I have patients come in every day and they're like, I've got to be honest, I didn't do the exercises, and then we have a conversation like, well, are you feeling better? Did any of the other things work? Did posture work? Did icing work? Is there anything that is going well? And then we kind of start with that positive part. And then we get into, well, if you want it to get any better than it is now, you have the opportunity here to add the exercises. And if you give them the guidelines as to, you are not likely to make this worse if you abide by the pain scale that we just gave you. You might not get better fast. I'd rather you come in and tell me I'm no better or I'm the same, than tell me that you hurt worse. So when we give exercises, sometimes change is slow. It's like dieting. You got to do it a little bit at a time and get a change over time. Perfect. So it's safe.
It's safe, and you're supposed to do it. It's good for you. Let's heal. Let's get to functioning.
If it hurts, then you either have the wrong exercise or you're doing it at the wrong frequency, and we can adapt that. If you don't come back, then we can't help you because you didn't give us that opportunity. There's a little bit of trial and error in physical therapy. It's an art, not just science.
Perfect.
So Deanna, all of us are kind of like, because Kelly mentioned kind of fitness exercises or going to gym. We're all kind of, to some extent, guilty of not doing as much or not being consistent with exercise and activity. One of the things has helped is like this technique of pairing, meaning that you have already a habit established that you already doing on a regular basis, and you really don't have like any friction. You wake up in the morning, you have your coffee at night before sleep, you're brushing your teeth, so you really don't think about these things. So I always like tell my patients is like, pair a new habit with the habit that you already have. Make it stop and say, I won't have my coffee in the morning unless I do my 10 minutes of exercises. I won't have my, brushing my teeth at night. And that, by pairing a new habit to an existing habit, you create more consistency. And I'm one that say to tell you, we're kind of, it's a human nature. It's something maybe hurt less, or it's less, it just goes in the back burner, or you forget about it.
Yeah, no, that's great.
Perfect. I love that. I love that. Dr. Entezari, this next question is for you. So let's say I am just somebody that is struggling with shoulder pain, and I call the number, we provided, or I'm calling Cleveland Clinic, and I get scheduled with, let's just say in this instance, the physician assistant, Sean. How do I know that that's a right placement? Is it something that is that a great place to start? Or when I'm scheduling, what is the difference between somebody seeing somebody like yourself, who is the orthopedic surgeon, versus somebody seeing a PA?
Sure. I mean, that's honestly the answer to that is like onus is on me or every practice that has a physician assistant in them practicing. So in case of Sean has been in practice for 7 years, only taking care of shoulder problems. And I sometimes feel like he has more depth of knowledge specifically in the shoulder area than some of my orthopedic surgeons that are practicing general orthopedics and might necessarily focus on one area. So one piece of mind that people who call Cleveland Clinic, and kind of seek care is that I will never ask Sean to treat a spine problem, or never have a physician assistant that works in the foot and ankle department to treat a shoulder. So these are not like just any physician assistant that you will kind of get, paired with. When you're calling a subspecialist office, this is a physician assistant that has worked with the subspecialist for extended period of time. So they know the, protocols if the patient comes, and, what imaging studies are required, what essentially how, let's say you had a fracture in your arm, how you approach, because fractures are very different. Your approach to a proximal humerus fracture is very different your approach to an ankle fracture. You get the ankle fracture moving right away because it gets stiff, but if you move the shoulder, parts and pieces are going to move, and there's a kind of nuances to these processes that speaking for Sean, I would say he is very well trained, has a wealth of experience. And again, he does not perform surgery. And that's where the transition of care comes when, we, on a weekly basis, we have discussions about cases that we see. And then okay, this patient maybe reached at the point that he maximizes the physical therapy or conservative treatment, had 1 or 2 injections. And again, the injection, for instance, I will have Sean inject my shoulder because he has been trained, through this process to kind of it's not, I don't think you should look at it as you're getting less of a care. This is essentially simply in provide more people opportunity to be seen. And then when it comes to more important decisions, certainly certain decisions about surgery, we'll just have this transition to my practice so we can talk about more the nuances of the surgery. And that transition is not always automatic. I'll see someone and say, yeah, I'm maybe a different approach to therapy, different approach to injection might be right, that we will discuss. And the nice thing is John and I see patients at the same time, see someone that needs another set of eyes, I'll walk into clinic and talk to the patient. So I would say we work very closely, and also he's very well trained. And at the clinic, I would say we make sure that a lot of these conditions are in place. So a physician assistant you're seeing is a subspecialized physician assistant.
Perfect. Thank you very much. I'm going to ask one more question to both of you, and then we will wrap up. One question, I'm going to start with you, Dr. Entezari, is why does shoulder pain seem to be worse in the morning or late at night? Why is that shoulder pain worse at those times?
It's cool. It's a good question, because I at times have parts my knee hurts, and as a person I've experienced this not just looking at it from a doctor. So I think there are multiple reasons. The way our perception of pain a lot of times comes from the internal hormones that are in play in our body, and we tend to actually have higher levels of internal cortisone in our body during the day for dealing with like, busyness of the day, just going to work, like, there's like a lot more happening, and we go through these cycles that these hormones actually fluctuate in our body. And that's one of the reasons is that we have like naturally more internal ways of dealing with pain and discomfort during the day because of that circular, like, rhythm of hormones that makes us appreciate the pain less. And people have looked at this. Also, there's less distraction, late at night in terms of just like sensory wise, where like, there's darkness and, just being at night allows you to kind of focus more on your body versus like, distractions that are outside happening. And it happens all the time. It's like, you go out, with friends and, you're busy, having good time, and you twist your ankle and you don't even notice. And then you come home and you realize, oh, my ankle is swollen, that I completely, ignored that. And it's just a part of that is the sensory distraction that we tend to have during the day. And also there's some physiologic effects of like, hormones that makes us deal with pain much easier. Another kind of corollary to that, the question I a lot of times get is like, do I do warmth or cold? Like, do I do that at night?
Yeah.
Do I do that at the day? So again, not a lot of science about like these interventions, but I would say, generally speaking, your ice will have an anti-inflammatory effect. So also heat and cold will allow the joints to tend to move better and gives you less stiffness in the joint. So I a lot of times ask patients to maybe do more of heat and warm bath and all of those in the morning. We tend to kind of wake up at night, where our bodies become cold during sleep. So a warm bath or warming up your body or putting, warm compression makes the joint move better and go through the day. And maybe have more of a cold compression, icing, and all of that at night, or after, Kelly had a chance of working with your shoulder, and so that, you reduce the amount of like, inflammation that comes in. For the same token, when I operate on someone, like, we constantly tell them ice the joint, ice the shoulder, so that the swelling that comes from the surgery gets reduced. So those are kind of, just general questions along the same line of like, what kind of changes during the day happens and what works when.
Perfect. And then, Kelly, the last question that I'm going to ask you is, you did a great job of describing the sleep positions. When someone is going to sleep and let's say their right shoulder is hurting, should they avoid sleeping on that side totally, or is it safe to do with the modifications that you had recommended?
We try to keep people in the position that they prefer to sleep in, if that's possible, because they're going to get the best night's sleep if they're in a position they're used to. But sometimes you have to change your habit. So we let them try. The biggest thing is people tend to have too small of a pillow. And so when they have a small pillow, they have to lean down to get to the pillow, and that kind of pushes their shoulder into the bed more. So if you have a firm enough pillow that keeps your body in alignment, you can usually spend some time on that shoulder. But certainly the position of your elbow being below your shoulder height when you sleep is important. I can't make this work. So the other part, so yes, you can sleep on the shoulder. Some people say they're best on the painful shoulder. So it does vary by person. And then supporting it, if you are a back sleeper, then you put a towel or a pillow or something behind the shoulder so it's not just hanging back to the bed. So it's usually about pillows and towels and positioning. And we do the best we can with that.
Perfect. Thank you so very much. I want to take this time to thank both of you for everything that you have shared with us today. It has been a real pleasure working with you on this event, and I know that our viewers are probably very grateful for the information. So thank you both. It has been wonderful working with you. Thank you so much for your time. I want to let everybody know before we wrap up what is next and what is coming your way. So in about a day, you're going to be receiving an email from the Cleveland Clinic that contains this recording. So if you want to go back and you want to learn a little bit more about something that maybe didn't sink in, or you missed something, or you want to share it with a loved one, or somebody in your life that might be struggling with shoulder pain, that's what you can do with this email. You can go ahead and share it. You can rewatch it. So that is going to be coming from the Cleveland Clinic in about the next day. So please keep an eye out for that. In addition, you can certainly take a look at some of the resources that we've provided in the chat function. And of course, please feel free to contact us. You've seen several of these flyouts where you can schedule with a specialist today. Please go ahead and contact us, and somebody from the clinic would be more than happy to answer any questions that you might have or can guide you appropriately to schedule to see. Thank you both once again very much, and thank you to our viewers for making this a wonderful event. We want to thank you all so much. Have a wonderful day, and it has been such a joy being here with you.